Okay, everybody, why don't we get to our seats if possible? We're going to start our final presentation of the day. It's been a fun day, a lot of great information, and we'd like to try to stay on a schedule as close as we can. So, again, some quick housekeeping notes. I know I've been saying this throughout the day, but please do remember before you leave to fill out an evaluation form. That's very important for us. Gives us more ideas about content for upcoming conferences. You also have the registry forms to consider filling out, as well as that yellow form for the remote health monitoring study. So please try to remember those too. Okay? All right. For those of you staying and are going to be getting CEUs, the CEU will be set up right at the same area as the registration desk. So come see us over there and we'll get you your CEU right away, as long as you've paid, and then we'll be out the door and we'll be set to go. So thank you so much. Okay, I'm going to give a couple minutes here to settle, to get set out. So, everybody, there's a supplemental handout that's going to be coming around. Veronica and Emily will be passing those out, so please be on the lookout for those too. Okay. All right, so let's get started here. So we give our final presenters the benefit of time. So as you could see, one of the things I wanted to do at the conference here today was to bookend it. Bookend it with models of what I would consider optimal dementia care, or at least models that are on the path to optimal care for people with memory loss. Essentia was one system that I think is really trying to make gargantuan steps in that direction, and Allina is the other. And so I was thrilled when Sandra Schellinger and her team agreed to tell us a little bit about a model that they've been implementing system-wide in Allina that has a great deal of relevance and importance to memory care. So Sandra, please.
Great.
Appreciate it.
Great.
They're coming around.
They're coming around. So thank you so much for staying. So the last one has a lot to live up to when you have some great speakers prior to them. So my name is Sandy Schellinger, and I work for Allina Health in the Division of Applied Research. I'm an advanced practice nurse in hospice and palliative care, and I've had the privilege to do research and really try to figure out an innovative way to support people in the last few years of life. Judy Blomberg, the care guide from our intervention, is here to also help with the presentation. We're going to hopefully keep this a little bit interesting, knowing it's the last presentation for the day. There will be a little bit of video, and we're going to put you to work halfway through. So you guys need to kind of be on guard. So I say live life fully and according to what matters most to you. So I really appreciate, Lisa, that you brought up Atul Gawande's book, because his message is just true to really how we all should be looking about living our life to the fullest. The later stages of life, even with serious illness, should be filled with purpose, meaning, and joy. The later stages of life should be a time when individuals can make personal choices based upon what matters to them, and at a time when they are recognized as a whole person. They have medical and non-medical needs. They're not just an illness. So that's the message that I really want you to think about and remember today. Judy and I are excited to be with you to explore what it takes to actually maintain a sense of well-being and live a life of meaning and purpose in the last 2 to 3 years before death. Our CEO, Dr. Penny Wheeler, is just a very inspiring leader, and it's, I think, telling that we're in an auditorium that has Hubert H. Humphrey sitting next to us. And her mission for the time that she's in from her leadership position is, she said, we have a moral and an ethical responsibility to tend to the dawn of life, the shadow of life, and the dusk of life. And what that means is we have to provide a very human-centered, person-directed, family-oriented type of care as we serve people no matter where they are, if they're beginning their life, or if they're in just the throes of life in mental health, mental illness, which is a great gap in care today. We have to realize what those needs are. And then as people get closer to the end of life, we have to do just as much to create that human-centered approach. So Judy and I don't have any financial relationships to disclose other than the Robina Foundation funded our research for the last 4 years. I do mention a website that we have developed as a result of our research, but it's really more consumer-based and really to help inform and create more of a public awareness and social movement, which I will give that to you later on at the end. So first of all, I'd like to kind of get a sense of those who have attended. Who is here today because they're either living with memory loss or you're a caregiver for someone with memory loss? So almost everybody in the room. How many of you are health professionals that actually support people with memory loss? Okay, so there's a little bit of overlap there. So over the next hour and a half, we will share what we have learned in the delivery of a late life approach for caring for individuals living with serious illness using a lay healthcare worker. And initially, we'll share results and an overview of the life course approach. And then the remaining of the time together will be focused on describing examples of what might be important for you to consider, whether you're a caregiver, a health professional, or the person living with memory loss. Examples of what might be important for you to consider if you're in the throes in the midst of that experience. So at the beginning of the day, we kind of focused on medical care and the medical system with pharmacy and a new approach to care. And then we were fortunate to have Lisa and Venerine provide their lived experience, which is so very, very important. We have to start with the perceptions of what people are actually experiencing in their life before we can really decide what's best for them based upon our medical expertise. And again, what I hope you leave with today is really more some practical information so that if you are receiving care or you're the caregiver providing care, that you have an optimal experience and quality of life. So what do we know about serious illness? We know, and it's a fact, that 8 out of 10 people will die, and they'll die with a serious illness that actually lasts over years, not just weeks or months. We also know, and I think we heard it in all the other presentations, is that fragmentation occurs, and it occurs across multiple settings. People have multiple providers with different care plans, different medical records, different perspectives. People who have memory loss have multiple medical conditions, and oftentimes those treatment plans are in conflict with each other. And the last place where fragmentation occurs, and it's a very loud message we need to hear, is that between patients and families, we fail to honor the central disease management role that they play in the health and welfare of their loved one. So as we think and round out today, we all need to think about how we're the solution. We're going to present to you one part of a solution that's probably a bigger issue, but we all need to be the solution to think, how do we do this better? How do we support people that have serious illness? It's just all people with serious illness. And it's not about good hospital stays or good hospice or end-of-life care, but the whole time that they're living with the illness, so the gap between the medical care and support that they receive. So we heard earlier some statistics around Alzheimer's. It's the 6th leading cause of death. It's the 5th leading cause of death for people over the age of 65, and if you are of color, of a different race or origin, that's even another different statistic. Today we know there's no treatment or cure, but there are things we can do to actually maximize quality of life and adjust to the changes while being prepared for the end, and that's what I'm hoping you'll get out of today. So as an introduction to serious illness with memory loss, we'd like to share with you a video clip from one of the Life Course documentaries, and it's titled Late Life, Facing Dementia. You'll be seeing different clips throughout today, but you can see the full documentary on our website, which is on the last slide of your PowerPoint.
The number one question asked by the general public is, what is the difference between dementia and Alzheimer's disease? Dementia is a word that describes a set of symptoms, but it's not a disease in and of itself. Dementia is caused by many diseases. Alzheimer's disease is the leading cause of dementia.
We'd go over to visit her, and I would just notice the small little things, you know, like the repeating in that. And I remember bringing it to Don's attention, just saying, you know, we got to start thinking about something with your mom.
Age is the greatest risk factor for Alzheimer's disease. Currently, about 10,000 people a day turn 65 in the United States, and that is expected to happen for the next 20 years.
It's almost as if I am the adult and she's the child, like it was when I was a kid, and I'm sure she had to do the same thing for me.
About 1 in 10 people at the age of 65 develop Alzheimer's disease. That number increases to about 1 in 3 once people reach the age of 85. So we're witnessing a veritable tsunami of Alzheimer's disease and related disorder cases.
I don't have no idea what's gonna happen. No, I don't wanna know. I don't wanna know the worst.
Alzheimer's disease is a chronic disease. It's a fatal disease, but it's a very slow, progressive illness.
We know what the future will hold. It's just a matter of embracing every moment.
I really don't know what's going to happen tomorrow or next month or next year. My mantra in a way is live in this moment, do the best you can today, and not worry about tomorrow.
While it's very scary when people get a diagnosis, I think it's very important for people to have hope and to realize that it is possible to live well with Alzheimer's disease.
So again, you can see the rest of this documentary on our website. So how many of you believe that we all have a 100% chance of dying? Right? Okay, so I need to put a little bit of humor in here because what we're talking about today is really the end stage of that memory loss journey. And how do we live that time to the best that we can? And what we need to think about is what that might look like. How many of you would prefer to die of cancer? A few, okay. How many of you would prefer to die of heart, lung, or kidney failure? None of them are good options, are they? I know, keep going, right? So, for those of you that didn't raise your hand, you're likely to die at an older age, and that's a good thing because we've got a lot of medical technology. But we will die of old age and a general sense of brain failure, such as Alzheimer's or dementia. Or we'll die of a generalized frailty that includes multi-body systems that are just kind of breaking down. And over time, we'll experience weight loss, we'll have diminished physical, functional, and cognitive capacity. And in the end, we'll probably die because of some minor event. Might not seem minor to us at that time, but it's a minor event such as an infection that we aren't able to overcome. We have an injury such as a fall that because we're so frail, we're not able to heal. Or we might experience what we call dwindles or failure to thrive. No matter what we do, just the aging process keeps marching on. And for most of us, this dying actually may be a very ambiguous time that's drawn out for years. I know you're probably saying, well, she's a Debbie Downer. Well, the idea is I want you to kind of see of what does this experience look like. And the challenge, and you've heard a little bit from our previous speakers, is that over this illness trajectory, there's no real one thing that shoots out at us that's good or bad or indifferent. But what happens is that there's this constant tug and tension between honoring the individual wishes and preferences of the person with memory loss or the frailty, and the family's increasing role of assuming complete responsibility for care and support at the end of life. So it's just a huge shift that happens over time. How many of us have said it's just old age, or I forgot to take my dementia pill today? How many people are accused of that? Well, really, when you think about it, 3/4 of us will lack decision-making capacity or some sort of memory loss at some time before we die. It might occur as just normal aging where we're forgetful and we remember things and we're actually able to still live independently on our own, but we're just forgetful. Some it might be because you've got medical conditions, and during those acute crises for those medical conditions, either because of the medications you're on or side effects of the treatment, you have memory loss or you lose decision-making capacity that you may or may not recover at that time because of how serious that complication might be. And then there is a level of chronic progressive memory loss that occurs when there's repeated injury to the brain, and that can happen in a lot of different ways. Strokes, repeated strokes. If you've got heart failure, lung disease, or kidney failure, you might not get the circulation to your brain, and it might be more of a ischemic dementia, or it might be in the presence of progressive dementia symptoms that you have with Alzheimer's or dementia. And for serious illness, I'd like you to think not just about Alzheimer's and dementia or memory loss, but I'd like you to think about brain failure during this time, during the last 2 to 3 years of life. Because people might have periods of brain failure many times throughout that illness trajectory that you saw. They aren't able to speak for themselves. They're relying on you as a caregiver to support them to the fullest. These people have lost executive function and their ability to care for themselves, and they're totally relying on others. Again, you may or may not think this sounds good to you, but despite this, I believe it is possible to help people live fully during that time. Since 2012, we have been really fortunate to have been engaged in research, and we've been researching what it would take to serve all people with serious illness. And how do you do that in an upstream approach so that people have this care 2 to 3 years prior to the actual dying experience before they'd enroll in hospice? This short video will provide you an overview through the voices of the patients, the families, and the actual care guides that care for these patients.
I'm a diabetic. I have congestive heart failure. And I have now kidney failure. I don't get up and down the stairs very well. And as far as laundry, I don't get that done very well. As far as meals, I don't get that done very well. Some things seems easier to do than others. Same as like it's easier to come out here than to go in the kitchen and fix a meal.
I come out about once a month, and generally we have a chance to catch up on what's been going on. Just reviewing some of his advanced care planning, looking at personalized aspects to how he prefers to receive and view treatment. We had the pharmacist come out once to talk about medications that he's taken and just understanding of what they're doing and having conversation around what Mr. Dixon sees as important and working well.
One of you might be able to smell this. It's a beautiful smell.
Oh yeah.
Growing a vegetable to eat or a flower plant to look at gives me that joy. It's just a passion in me that I love gardening. I love farming.
As treatment of chronic disease becomes more involved and lifespans increase, patients and their families can feel overwhelmed. From multiple specialist visits, then numerous medications, to financial, spiritual, and emotional stress, persons with serious illness and their families can fall through the cracks.
Life Course is an innovative approach to supporting patients and families who are in their last few years of life. So folks who may have advanced heart failure, they may have advanced cancer, advanced dementia, COPD, Parkinson's, any of a number of conditions. Healthcare does a really nice job of taking care of folks when they're in the hospital. And then we do really good when folks get very near the end of life. What we don't do is well in between. What can be months, what can be years of time that a patient and family will face, struggle with, be overwhelmed by advanced serious illness, and to, on some level, abandon folks during that long period. I think it's something that we can no longer do.
How are things been going?
Well, pretty well. pretty well.
Very well.
We use in the life course model a lay healthcare worker who has likely life experience supporting someone with really advanced serious illness, but isn't a trained clinician. We call them care guides, and their job really is to partner with them in navigating the system, in navigating the other systems that they may need to intersect with, so not just healthcare, but social service systems and some of the other social assets.
They joined almost 2 years ago. And then we started meeting, and as I look back, it was monthly. We talked about both medical and non-medical concerns in my visits.
She's kept in close touch with us and referred us to people that we needed to be referred to. She's been a real resource person for us.
She listens to me. I talk and she listens.
When patients talk about what matters most to them, what ends up showing up less than the majority of the time are their physical health needs. So beginning to understand that 70% of the time, it's about all of the other aspects of self. And so this has given us a way to ask about that, to be able to capture it in the record, and then to be able to, with patients and families, develop that plan.
What you've helped me do is write a story that's now in your medical chart that includes those details that haven't been there in the past.
What we really are trying to do with Care Guide partnering with an individual and their friends and family members is to engage in an empowerment model, to be clear about what matters most, and then to really enable them to engage their primary care team members, their specialty care team members, but more importantly, all of those supports that exist outside of a healthcare system that they're going to need in those, last several years.
I came to grips with my mortality a year ago, February.
There's a continuity in relationship that seems to be really important to our patients. I'm still there even when they've transitioned into another level of care.
By coming to grips with that, I found peace. And that's available to anyone.
I think he's taught me a lot about how to approach a serious illness with hope.
The last project Bob completed is a book chronicling the last several years of his life and his thoughts on death, called How to Live Well and Finish Right. It includes a dedication to Judith Blomberg, his life course care guide.
Late Life is a production of Twin Cities Public Television in partnership with Allina Health, whose Life Course project, funded by the Robina Foundation, granted the producers unique access to their ongoing research into late life care in Minnesota.
So he was a great man. He taught us a lot during our research. As you can see, we're really trying to perpetuate a very human-centered, relationship-based support system that focuses on the patient to direct their care. It includes family to help them across the whole trajectory. And so to date, we've actually enrolled over 1,800 people in our study, which is a pretty good size and amount. 450 have been patients, and then we have 450 comparison patients. And then we've enrolled their family members, which is really unique to research. So we're actually including families at the time of enrollment and at time of care. So patients, the families are with us throughout that process. This year we're integrating the model into primary care and specialty care clinics. And we're doing final data collection so that we can actually finish our final publications next year in 2017, along with continued integration into our health system. And what we have found to date is that the life course participants and family members, their quality of life remains stable, or it declines less over time at a slower rate than the people that do not receive the care, and they have a better positive care experience. We also see that they utilize community resources as well as inpatient palliative care at a higher rate. They don't go to the hospital as often. They stay home where they want to be. They have a dramatic increase in advanced care planning discussions and advanced directive completion. And we also find that they choose to enroll hospice at a higher rate. So what does it take to do that? And we found that there's 4 key things that we really need to focus on. One is someone to help support this long-term relationship. And so we chose to hire lay healthcare professionals to actually act as a consistent contact and communicator for the patient and family across care settings and organizations. And they use a family-oriented approach to really understand what strengths do they already bring to the table, because we're not there to do 4 or do 2, but we're there to be with them, help them understand what they can do on their own, and then help fill the gaps in between so that they actually feel connected to the supports and resources that they need. And then each visit really starts with what matters most to you. What do you hope for? What do you wish? What are your preferences? And then make sure that those are communicated to the care team so that it actually supports the medical plan that they have rather than being into a box of a generalized disease guideline. And then care guides promote whole person care by asking questions and then connecting them to the supports that really would help them with their physical and psychosocial needs. As you see here, this is Leah, one of our care guides, and the care guides meet in the patient's home on a monthly basis. They are lay healthcare professionals that we've put through specialty training in aspects of palliative care. They possess excellent communication skills, and we're looking for people that have personal or professional background in working with someone with serious illness. They have good teamwork skills, and they're motivated and can work independently. And they're expected to manage a caseload of about 45 patients and families, and they meet with them over the course of the last 2 to 3 years of their lives. To date, by the end of this year, we'll have hired and trained about 30 different care guides, 15 of which were part of the research, and 16 will be with the integration into the health system. So what do they do? As I said earlier, they visit patients and families monthly, and they're in-person visits, and they always start out with understanding what people's preferences and goals are. What happened since the last time I met with you? What's important now? What's changed? And what matters most? And based upon what matters most, what are you actually willing to focus on? So if you think about diabetes and managing diabetes, the A1C is the thing that you need to meet the mark on. For someone who has an advanced or serious illness, meeting those disease guidelines are really probably not the focus. We have found that only about 40% of the time, physical types of goals are on the minds, front and center, patients and families. 60% of the time, it's all other aspects of trying to live well. So they understand what these personal goals are, and then at each visit, they explore the medical and the psychosocial needs through whole person questions and assessment tools. And this then allows them to understand where there might be gaps and to connect the patients to their care team members or community resources. So the Alzheimer's Association actually gives us a very nice roadmap to think about for serious illness and brain failure. And I think they're really good key points, and we've heard them messaged throughout the day, but I think we just need to emphasize them. That you need to recognize the early signs of change, whatever is happening to you. So know what those early signs are and understand your illness. And have conversations. It's about understanding what to expect, not just about your medical condition, but how's it going to affect every other aspect of my life. Know about the other medical conditions and how that might affect the brain failure that you have. And then probably most importantly, because as people progress down this brain failure trajectory, they can't express what's important to them over time. And so share worries, concerns, and hopes and wishes all the time, and make sure you're sharing those with your healthcare team. This actually will help you plan for the future. So if you're having those conversations, it will actually let the people that are caring for you know, oh, that's really important. Then what I was going to do for you is probably not as important. I'm going to change what I'm going to do. So what matters most? As serious illness progresses, it is important to engage and re-engage in what matters most. When people talk openly about that and what matters most, the healthcare providers, family, and close friends can better support them as they navigate the challenges of life. We have found that some people with serious illness, they want to better understand their health and healthcare options and have a say. Others may wish to honor cultural and religious practices. Some may simply want to attend a family reunion or a family event, while others may want to maintain a sense of normalcy, and I put that in quotes because you have to understand from their perception what does normalcy mean. Some want to nurture and renew family and relationships. Others really want to recognize and sustain what they think a meaningful purpose in life is. So in the remainder of the time that we have, this is where the interaction comes. So you're going to have to participate. We think that there are all aspects of life that are important during serious illness. We think the physical illness, the physical aspects, how you are mentally healthy, how are your social networks, how is your family and caregiver play into this? From a cultural perspective, what's unique to you? How do you look at the world? What's your worldview? And where do you gather your strengths during tough times and challenges? Is it through your faith, a community? How are you thinking about helping others understand a life worth lived? Are there legacy work? Is there legacy things that you'd like to do? Are you experiencing current losses and grief? With advanced and serious illness, you have a cumulative loss over time. So how does that affect you and your other family members? End of life is a piece that you need to think about since this is an advanced illness. And then what are the decision-making things that you need to do, as well as financial and legal? For our remainder of time, since we only have a short time together, we're going to focus on 4 different areas: the physical, family caregiver, ethical, and end-of-life care. And as we explore these aspects, I'd like to introduce you to a couple of people. I've changed their names, details, for privacy purposes. Douglas is 80 years old. He's living with Lewy body dementia, Parkinson's, he has cardiovascular disease. He's single, never been married, and his friend Jennifer, significant other, is his advocate. Being wheelchair-bound and cognitively impaired, he needs to rely on others for all his needs. Edward is 92 years old. He lived with his wife, Martha. He is living with Lewy body dementia and has a very complex medical history that includes prostate cancer, cardiovascular and peripheral vascular disease, atrial fibrillation. He's got significant pain, vision, and hearing loss. Due to his significant cognitive deficits, he relies solely on Martha for everything. So we go to Martha for what matters most, and for her it's focused on spending quality time with Edward and helping him to adjust to a new living situation. So the next piece, we're going to do, show you a short video. We're actually going to have a little bit of a discussion and then show you a short video. So the handout that all of you have, I'd like you to look at page 1, if you can. This is a serious illness discussion guide. Can you raise your hand if you didn't get one? What I'd like you to do is please begin with reading item number 1, the physical statement, and respond based upon your own experience or your opinion. And just do this, as kind of your first gut reaction. And then I'd like you to take a minute or 2 and talk to your neighbor about why you chose what you did with that statement. So if you would take a few minutes to do that. Oh, we're on time. That's great. Yeah. Oh, all right. It's hard seeing back. I know. It's neat. It makes me so he was a very sweet guy, wasn't he? Yeah. Right. That's so many people are to take. I know. Sounds like this statement was pretty powerful for you. Lots of conversation. If you can try to finish up, that'd be great. I won't ask you to publicly share. So I'm going to show you another video clip, and it's going to provide you with a family's perception of memory loss and the various ways they chose to recognize and manage it. And I want you to look at this as one family's perspective and really, hit the home run in really the message that it's starting with each person's perception of what's happening to them, their past life experiences, and what they bring to the table. So it's really important to understand individual perceptions around what they're experiencing.
We are so blessed, so thrilled, and so excited to be residents of Edina.
To prepare for the increase in Alzheimer's cases, communities across Minnesota are leading the way in becoming dementia-friendly. Edina is one of 34 communities so far who've taken a pledge to provide a welcoming place to live.
We are here to tell you there is life after a diagnosis of Alzheimer's. The years before, as well as the first year after Ken's diagnosis, were not easy.
This was the Act on Alzheimer's Edina community meeting to report kind of the work that we had done in 2014, trying to make Edina more dementia-friendly.
Our daughter asked, "Mom, I'm just really having a hard time with Dad's diagnosis. I really would ask that we just not talk about it."
First priority is learn about the disease and what you can do if you're interacting with a person with the disease or reaching out to a caregiver.
We went to our Episcopal church not too far away, but of course we didn't tell anyone yet. We didn't want their reaction to be the same as our daughter's.
Alzheimer's disease is very isolating. Many people don't know how to react. They want to help, but they're not sure how. The best things they can do for their neighbor, for their friend, is to continue to interact, to be patient, to be kind, to be welcoming, to continue to invite.
We were really experiencing the lowest of emotions with the disease, but we met a wonderful care consultant, and we were able to turn our despair and depression to truly one of hope and acceptance of the disease.
So I think what will come out, hopefully flower in 2015, will be all the different ways as we all become aware how we can reach out to caregivers and people with the disease.
It is through God's loving grace, our loving support of children, and the Alzheimer's Association that Ken and I made the decision and the commitment to work together to make a difference for others living with Alzheimer's.
It's something that we needed, and if we can give back in any way, I think that that's where we are, all walking together through this.
So staying healthy or helping a loved one stay healthy can be challenging when you have one or more medical conditions. We are often faced with increased treatment burden, pain, and symptoms and functional decline as the illness progresses. So when you think about the physical domain with serious illness, you need to ask yourself at times of a new diagnosis or new symptoms, hospitalization, functional changes, you will want to ask yourself what is new or different about your illness, what's the treatment plan, how is it different, how this affects your ability to function so you can better recognize when to connect to resources. So I'm going to turn it over to Judy, and she's going to share her personal and professional perspective as a care guide.
So on your sheet, the discussion guide sheet, if you'll turn it over to page 2, I'm going to walk you through how I, as the care guide, address the physical aspects of a patient's illness with the patient and the family. But as Sandy mentioned, I have both personal and professional experience with Alzheimer's disease. I am the caregiver for my mother. She is in the late stages of Alzheimer's. I personally know how difficult it can be to get a diagnosis. And I was talking with my brother actually last night, and we agreed we didn't even know we needed a diagnosis for a very long time because We saw strange things, but we never understood this was really an illness for her. And eventually we got the message, this isn't going away and it's getting worse. We need to know what it is. So we did get her tested. We got a name for it. We began to understand better how we should plan for her care needs moving forward. So the questions, if you'll look on your paper under physical, I'm going to read them to you and then review with you how I would go about using those questions. Our hope is that they might be helpful to you, using them with the patient who is in your life, or even just for yourself to kind of reflect on your understanding of the illness. So the questions are, the physical, what do you understand about your current condition? How would you describe your current treatment plan? What symptoms do you experience are most bothersome? How has living with this illness changed your life? So in our video, it was suggested the first priority is to learn about the disease. So these questions that I have just read are intended to help patients and families know more about the physical aspects of the illness. I want to share with you the story of one of my life course patients and how he gained an understanding of his illness. Sandy has introduced you to him. We're calling him Douglas. I met Douglas and Jennifer a year ago in 2015 when Jennifer enrolled Douglas in our life course research project. I have visited them on a monthly basis since June of 2015. Jennifer is Douglas's close personal friend. Douglas has siblings, but just like in the video, they're not involved in his care decisions. In fact, Jennifer has told me because they believe this could be a hereditary illness, they're afraid of it, and they visit him infrequently. She is his decision maker. She shared with me the story of Douglas's illness and the difficulties he faced in getting an accurate diagnosis. So for Douglas, 10 years ago, he was evaluated by his primary care physician for short-term memory loss and tremors. His doctor's notes say that Douglas had a partial workup with a neurologist. Her notes also say he could not afford to pay for neuropsychometric testing, so he did not have that done at that time. His doctor questions, is this short-term mild memory loss really a case of dementia, or is it in fact an aspect of his depression? And I want to add that Douglas has had and has continued to have over these years an excellent relationship with his primary care doctor, and she has provided him with excellent care. But they were in a place where it was hard to know exactly what she was treating. He continued to have these symptoms, but of course had no real understanding of what was causing them, not really a treatment plan, and symptoms continued to emerge as the condition worsened. What mattered most to him at that time then was getting a diagnosis so he and Jennifer would know what his condition was and what did they need to do to have it treated or at least well managed. 2 years passed before he was able to afford the testing that he needed. And I think he and Jennifer were fortunate to find an excellent neurologist who specializes in Alzheimer's disease, Lewy body dementia, and Parkinson's. His neurologist has offered, I think, some great quotes about how he approaches these kinds of illnesses. The doctor has said, I deal with the unimaginable. To live gracefully with something that is completely foreign and impossible to consider. I will add, too, that the neurologist himself, his mother, had Alzheimer's, and that's why he's chosen to treat this particular group of patients. He added that his treatment plan, again, this is the neurologist speaking, is improving the ability of caregivers to care for their loved ones. And I will say that that relationship with this particular neurologist for Douglas and Jennifer was excellent from the start and has remained a strong source of support for them to this day. After this evaluation, Douglas was told he had Lewy body dementia and Parkinson's. So devastating diagnosis. There's no question about that. But I think from what Jennifer has told me, they both felt relieved that at least they knew what was going, or had some idea what might come next, and to start to make some plans, both short-term care plans and long-term. So for Douglas, as his illness has progressed over these past 8 years, his symptoms have included frequent falls, hallucinations, and even more memory loss. During that time, he's moved to 3 different nursing homes because nursing home number 1 really was a great place for him, but he couldn't take the stairs. That was really what happened. He wasn't able to walk upstairs. And in that particular setting, he had to negotiate stairs. He moved a second time, and in that nursing home, he fell out of bed, and it was clear he needed more supervision, so he was moved to a different building in the same nursing home, which is where he now lives. But he's lost his ability to live independently, and he has to begin to rely now on someone else for all his care, the needs of daily living. Today, he cannot walk or talk. He is wheelchair bound. But his neurologist and his primary care physician have remained a very important part of his care plan, even while he's been at the nursing home. So, I know this sounds all pretty bleak. For me as a care guide, of course, I continue to visit with them, but my visits, because Douglas has never been able to speak to me since I've known him, he cannot communicate with me, but my visits are with Jennifer, and she's told me time and time again she has no one else to talk to but me, because no one wants to hear about is what she says, that his siblings, she calls them, but, they're kind of not too interested. And, her friends, this is not a cheerful conversation to have with them, or they just don't understand. They've never experienced this. So she and I sit, and, I allow her to process with me what is going on with her. But I have to say, she's a cheerful caregiver for someone who is so impaired. I've watched her do what she can to make Douglas's life the best that it can be. She brings him small treats that he enjoys because he can still swallow okay, thank goodness. As long as that's true, he can enjoy candy or those kinds of things. She plays music for him that she knows he enjoys, takes him to activities at the nursing home. What really matters to her most, because now she's speaking on his behalf, is getting his care needs met and then spending time together in the best way possible, given the advanced state of his illness. So getting back to our question set, the question set about Douglas's illness is used by me in most of my visits, because what I want to share with you is that as I see understanding of illness, it's an evolving thing. It's something we talk about all the time. Where do you think you are? What is going on now? What are you seeing? To help anticipate, not just to address the needs that are in front of us, but what the needs might become down the road, and maybe that change is coming sooner than we might think. So for me, it's really not, when we look at these questions, it's not just a single point in time, but it's something that I would review with patients and their families. And again, given the advanced state of the illness, in many cases more with the caregiver than the patient themselves. But I would review them every time I see them, and always wonder how they're doing, and use those understanding questions to get a read on where they think things are today.
Great, thanks. Thank you, Judy. So hopefully that gives you kind of somewhat of a perspective around how to think about and have ongoing conversations around your medical condition and how it's affecting your life. Let's go back to your discussion guide, and let's look at statement number 2, and it's around family and caregiver. So if you would read that, and then talk with your neighbor about how you responded, what was your opinion, what was your perspective? A little bit. We probably won't have as much time for questions. Is it? Okay. Maybe we can make up some time with this one, because you're going to do longer.
Yeah, I'll try that.
Okay. Yeah. It's just like it's nice.
I do too. That's why I said this is so real. I never go wrong when I let my patients speak for themselves. Honestly, they teach me everything I know pretty much. If I were open to it, I do.
Right. All right, it sounds like there's a lot of energy around family and caregiving. Let's try to finish up here. All right. We'll pull back together and watch another video. Okay, so this next video will provide you one family's perspective on challenges of caring for someone living with memory loss in the advanced stages of Alzheimer's disease.
Who is that?
That's my mother.
That's your mother.
Carlton Garner moved his mother Marie from Alabama to care for her in his St. Paul home. He manages the mounting responsibility by arranging for Marie to receive both in-home and adult day services while he continues to work and take care of himself.
Actually, she's doing quite well, considering the disease itself. But she has regressed. I have to give more commands of what it is I need her to do. I have to stand over her to make sure that she gets it done. Just not able to remember the basic things that you and I take for granted.
So when people know that there's a brain disease behind the symptoms that they're seeing, they have an explanation for the symptoms that they're seeing in their day-to-day life. And it also opens the door for them to seek help.
The disease is what it is, and I can't change it, but I can change how I approach her. So I'm more patient. I'm her voice. I'm her eyes. I make sure that she's safe and she gets everything that she needs.
There's no right or wrong way to take care of someone with Alzheimer's disease if you're patient, kind, and supportive of that person's needs.
It's something that I enjoy. This is an opportunity for me to give back to her, even though it's difficult. I have a full day, I have to work, and then my job doesn't end when I come home.
Caregivers need time for themselves, even just to go to the grocery or take a shower. There are many ways to be able to do that. There are home care services where people can come into the home. There are adult day services, which is a place where people with dementia can go. And we think of this as a break for the caregiver, but honestly, it's a real treat for the person with the disease as well, because they can interact with other people, be engaged, do activities.
We're on our way to the Wilder Foundation. You know where you go and you see all of your friends and you all eat and play games and read. You remember that?
I passed that stage.
No, you haven't.
The stayed at home today.
No. When you get here, you always have a good time.
How long are you gonna be gone?
Oh, about 3 hours or so. You won't even miss us.
We see our program as not just for participants. This is a program for caregivers. For Carlton, it's important for her to be here. He still works. And also, he can do what he needs to do during the day while his mom is at the program. And the satisfaction to know that she is well cared for.
Talk to her.
We hear that all the time. One-on-one is great. Right. Just get her face to you.
It allows me a form of respite, knowing that she's in a safe environment.
Respite is just another word for relief or taking a break, and pretty much anyone who's raised a small child, the 24/7 issue, can understand that every now and then to keep that going in a loving and supportive way, you need a break yourself.
But it's a difficult thing to do. The focus is on the well-being of the person who is sick, and that is normal, and that is okay. But we see a lot of caregivers pass away before the person with dementia because they're not attuned to their own health and well-being. This is a marathon and not a sprint. And if you don't take care of yourself, you won't be there to take care of your loved one with Alzheimer's disease.
So what do you think these are? Cucumbers?
Bell peppers.
Bell peppers.
It allows her to interact with people around her age. It also gives her a chance to continue to have some of the personality that she had. She always enjoyed helping people. She gets around pretty well. She still has incredible manners as it comes to dealing with people. So this gives her an opportunity to continue to use those skills.
With Marie, what we see in her is that we can meet her where she's at, meaning that we will provide the opportunities for her to be successful. So we know Marie loves to read, and she can still read, so we'll give that an opportunity for her while she's here.
Can you read them out loud for us? Yeah. Okay.
You can't be a hero without taking chances.
We know she likes to do exercise. She loves a gross motor kind of skill. She loves to dance.
Bring it up high, Marie. There you go.
So those are the things that we know about her, which is also very important, that we know their past a little bit and that we know their likes, and then we can really work for them to be successful.
It helps me because I know that she's having a good time, she's safe, and it's an outlet that keeps her going. So it's a blessing.
We did exercises, we went for a walk, she was dancing, she played.
I want people to know they aren't alone. This is a tough situation, and most families struggle because working and trying to keep them safe and keep them comfortable and smiling, that's not easy. She said she'll see you next week, okay?
I'll see you next week.
See you tomorrow.
Sure. Okay.
But she is my mom, and I wouldn't trade this position with anyone else because I'm having an opportunity to give back.
She's just delightful, isn't she? So this is not the 50-yard dash. This is a marathon. And as soon as we realize that for family and caregivers, and they're in it for the long haul, we need to recognize that the illness impacts them. They have to be part of the unit of care, and we need to include them at the beginning of care, not at the time of crisis. I can't tell you how many times as my dad had advanced heart failure, lung, and kidney disease, that I was called by him at 4 o'clock in the afternoon and said, I'm being discharged, can you pick me up at 4:30? He was hard of hearing, double hearing aids, and he was the primary caregiver for my wife my mom who was wheelchair bound. So there's just still a huge disconnect. So if you are a caregiver in a care setting, make sure that you're involving family early on, that you actually understand the social network of family and friends that patients and families use and partake with. And are they good assets? Are they strengths for them, or are there gaps? So how do we realize that? So Judy will talk about her personal and professional experience.
So we're going to again look at page 2 of the handout that we gave you. We'll look at the family questions. Before I turn to those questions, I mentioned I'm a caregiver for my mother. She does live in a skilled nursing facility. She's been 100% dependent on others for 3 years. She does not talk. She does not walk. She does not feed herself. But she is well cared for by, I think, an incredible team. I'm fortunate to have them. But it's been a difficult journey for her and for all the family. And I use these questions myself to look at her care needs. I will say for my mother, just like you saw in the video, she too was relocated from Iowa to Minnesota. Doesn't sound like as big a move as coming from Alabama, but she left behind lifelong friends and all her family that was in Iowa. But this is where her children happened to be. I myself moved here to help my brother with her care. So, you know, I can appreciate what that does when you have to move an elderly person so late in their life. The following questions that we're going, and one other thing I did want to add too, I too am in a support group and have been in a family support group for 5 years, so I endorse that was mentioned earlier. The questions I use with my patients and their families, again, if the patient is advanced, it would be with the caregiver, and the patient may not be participating, but either way I would use the same questions. How does your family support you now? And how might they support you as your needs change? And what areas, if any, do you need additional support? And then who would you like to have as the main person for communication? So Sandy mentioned earlier, we've introduced you to two patients, Douglas and Edward. So for this part of our discussion, I want to talk about Edward and his wife, Martha. So in the video, we saw how the patient's family was able to find community resources to help her stay in her home with her son as caregiver. So what I would like to share with you is what the next chapter in the story may be. What happens when the care needs of a dementia patient can no longer be met by the caregiver at home? The patient's story I'm going to share with you illustrates how these family questions I read can be useful to me as a care guide in supporting the patients and families I serve. So as I mentioned, this is about Edward and Martha. I met them a year ago, started meeting with them. Martha decided to enroll Edward in Life Course because at that point she knew they were reaching a crossroads as to whether she could continue to care for him in her home. Edward, as we mentioned, has been diagnosed with Lewy body dementia. Martha noticed and could not help but notice that he was experiencing further cognitive decline, and he was just in general physically weaker. He was at a high risk for falls, and when I first met her, she expressed concern to me about what will I do if he falls again? How will I get him up off the floor? So at my first visit with her, we looked together at some resources she collected because at the time I met them, Edward was receiving home health services paid for by Medicare. That care was going to end. Those services, had an ending date. And Martha didn't know, once home health care was not coming, what was she going to do? So she collected some information from visiting home agencies. We looked at it together. And, I was her sounding board. Is this an option that would be good for them? What would that look like, having these people come to their home? How much would it cost? Was this affordable for them? 2 months after I started visiting Edward and Martha, Edward did in fact fall at home and dislocated his shoulder. He was sent to the hospital, and while he was at the hospital, it became clear that he was not going to be able to come home again, that his condition had really changed so much that Martha could no longer care for him. And remember, Martha herself is over 90. So, a small woman, a strong woman, but none of us are big enough to start lifting someone, up off the floor after a fall, especially you don't want them to be injured. So a real concern for her. So I met with Martha separately after Edward had been in the hospital. He'd been sent to transitional care, so he was no longer living at home. And we talked about the changes that she was going to need to make and what kind of support he might need. She expressed great sadness that he could no longer live at home with her, but she was beginning to accept the reality of their situation. So we discussed the nursing home she looked at, prepared for a care conference that she was going to have at the transitional care unit. I then had separate conversations myself with a social worker at transitional care to share with her my knowledge of Martha and Edward, how they lived in their homes, and what I knew about Martha's willingness to have him live in a long-term care facility. After his discharge from transitional care, Edward was moved to a skilled nursing floor in that same nursing home where he'd been getting his rehab. Today, Edward continues to live at the same nursing home and he's visited frequently by Martha and his family. His children are actively involved in his care, but Martha remains his primary caregiver. Once a month, I meet with them together at the nursing home, and then I meet with Martha separately to discuss her concerns as Edward's caregiver. And again, she's told me I'm her sounding board, someone that she feels comfortable talking to. I listen. She tells me what's on her mind. One of the things that we've been discussing is, could Edward be moved to be closer to their home? Because right now, he's further away than she would like him to be in terms of distance that she has to drive. And the other thing is just looking at whether he needs some further medical evaluation. But those are how we would apply those support questions. And again, an ongoing discussion, not just a one-time thing, but always looking at how those support needs might be changing.
Thank you, Judy. All right, one last time. Look to your statements on page 1. This time, look at statements 3 and 4, the ethical and the end of life, and have just a short discussion. And we'll pull you back to watch another video, and we'll finish up with Judy talking a little bit about her personal experience and then open it up to questions. Like, we wanted to finish at 1:45. It's all right. I think I let him talk too long.
We're learning. We do this again.
We'll be more efficient next time.
We will. Save your notes.
Yeah. Actually, we should save these on the S drive in the folder because we can use this again somewhere.
Fine tuning it so for ourselves too.
Refer to them?
So long.
Yeah. Yeah, why don't you do that?
I don't know. If I cut those two things, I think I could be ready.
It sounds like there's some great stories being shared. If you can finish up in about 30 seconds or so. Okay, we've got one last video to share with you. The next video clip will provide you with a version of the end-of-life perspective with memory loss.
You can go see Grandma? Want to come see Grandma? Come on.
Ruth Stoops' Alzheimer's disease had progressed to the point where her son Don and daughter-in-law Barb could no longer care for her in their home. Ruth has spent 8 years living in a nearby memory care facility.
Hopefully she's in a good mood and things are on the upside for her today.
See Grandma? Should we go see Grandma? You're looking good today, Mom.
Thank you.
Looking good.
Yeah, this is kind of cool for us to see her like this.
And why is it cool for you
Well,
to see her
because
like this?
it's like the Ruth that I would remember before she became sick.
I was looking for you this morning and you were in the beauty shop.
Oh.
So.
What were they doing?
Washing your hair.
One of the bad things I think about this is in these later stages, she doesn't remember from 2 minutes to the next 2 minutes. And as people visiting, I just block it out as part of the disease.
She'll have no memory whatsoever that I was there yesterday and helped her pick out what she's going to wear and that we're coming, unless they've told her right before we come. Then she might remember.
She always liked Christmas.
Yeah.
You could talk about Christmas.
I
girl.
like that even as a kid.
What do you remember from back then, Mom?
Nothing.
I've learned that, as with anything, there's going to be good days and bad days.
A good day is that they're not agitated or sad for any reason, that they're smiling. Some residents dance, sing.
The good days, she's smiling, She's out being involved with recreation, whether it be calisthenics or music or the things that, they want the residents to be involved with. Those are the good days.
Bad day is when I come sometimes after work and probably don't even know I'm here because you're like laying on the bed and I might go like this and go, oh, you go, leave me alone. And I sit there for a little bit, but then I just leave.
Yeah.
I've learned that on certain days her personality is totally different. Like Ruth was never an angry person. Some days she can be angry and she'll do things that she never used to do.
Get me out of here. Get me out of here, away from her. She's an ugly person. I know.
Okay, aggressive. My mother never was like that. She was never an aggressive person. There's a part when she does, that's the bad days.
You gotta kind of go with how it's going for that particular day. Here, I just thought of another, could tell a good day. She hasn't asked the same question. You know how sometimes you ask the same question like literally 4 or 5 times. She hasn't done that. This is a good day,
I know she's not going to regain her memory. Hopefully nothing else goes wrong, okay? If nothing else goes wrong and she just progresses with the Alzheimer's and passes away peacefully and painlessly as could be expected, that's my hope. I hope that happens.
Say cheese.
Cheese.
I have no problem admitting that I probably will develop it. I have no problem with that at all. Am I scared of it? I guess kind of, but maybe I won't. Maybe I won't, but I got a sneaky suspicion.
Oh, I think about it. I know that someday, the odds are that he's going to get it. So, but I think I'm much more prepared than when Ruth got it. I've learned an awful lot.
She just wants to eat the candy.
So what matters most in that video? He hopes for a peaceful passing. When someone reaches the moderate to severe stage of memory loss, they are at a point where they have limited decision-making capacity or actually none at all. So upstream recognition of that shift in this decision-making capacity can really help promote proactive advanced care planning discussions when your loved one might be able to participate so you aren't guessing what they would want at the end. The mini-cog, as we talked about earlier today, is something that should be a regular part of care, which we do for our patients. Having this upstream conversation, it'll come in handy when the caregiver will have to make most of the decisions, especially about end of life as the illness progresses. There will also be daily opportunities to make decisions about care and treatment when the caregiver will need to determine if the choices are of value given the current level of quality of life. So there's a lot of burden on the caregiver at this time from an ethical and an end-of-life perspective. So Judy will finish up with her stories, and then we'll take some questions.
So if you'll turn back to page 2, in interest of time, I'm not going to read all these questions. You can refer to them as we're having this discussion. The ethical and end-of-life questions that I would use in my life course work as a care guide are intended to help the caregivers make those large and small decisions. If there's opportunities to still have discussions with a dementia patient, of course, those are strongly encouraged. And these questions are designed to facilitate those kinds of discussions. I'm going to return us to our patient Douglas that we mentioned earlier, who has the Lewy body dementia and is now living in a nursing home. I wanted to share with you how Douglas and his caregiver Jennifer have addressed these important ethical and end-of-life questions. So in 2010, Douglas was hospitalized and an advanced care planning session was recommended. When the nurse came to do the advanced care planning, she just assumed Douglas' cognitive decline was already too much for him to engage in those discussions. But Jennifer insisted she thought Douglas could participate and he could state his wishes, which in fact proved to be the case. He clearly stated his treatment preferences, including I want to die a natural death. He also clearly stated, I do not want dialysis. I do not want tube feedings. I do not want to be resuscitated. So those wishes were all recorded then in 2010. After completing that advanced care plan, his Lewy body dementia symptoms just continue to increase, as we've already mentioned, and into the state he is today where he is unable to communicate at all, does not walk, talk, and I think he can feed himself to some limited degree, but in general he's also has to be fed by other people. After he did the advanced care planning from 2010 to 2015, Douglas was hospitalized 11 times. 6 of those were admissions, 5 were emergency room visits. But it's clear from his record that he was benefiting less and less from that type of aggressive interventions at the hospital. As I mentioned earlier, Douglas and Jennifer joined LifeCourse in June of 2015. At that time, Jennifer shared with me her continued concerns about his treatment plan. She wondered, is his decline due to drugs, or is it the illness? Was it declining due to dehydration? Would more fluids change the course of the disease? Should he return to the hospital in the future? Douglas was often present at these visits, but of course not really able to communicate and participate in what we were discussing. As his care guide, I validated Jennifer's concerns and continued to help her find answers to her questions. I then collaborated with the nursing home staff. I found out from them Douglas had been aggressive and was uncooperative with his caregivers, so they'd had to provide him with some medications just so they could, care for his personal needs. His condition in the time that I've known him remained stable, and he did not have to be hospitalized again. But after they'd met with me for 6 months, Jennifer told me she felt he was sunsetting earlier. When I asked her what she meant, she said he's just not as alert. It's less and less time that he really can pay any attention to me. And she said, I've started to prepare his family for his death. And of course, for me, that was a good opportunity for us to discuss hospice care. She was interested, but didn't really know how to go about it. I went back to the nursing home staff who said, we're thinking the same thing. We believe he's eligible for hospice care, but we didn't know how to talk to her about it. So in my job, I was able to be the bridge between them. I set up the care conference with the staff and with Jennifer so that we could sit down and have a hospice consultation. He was then enrolled in hospice care, where he remains today. She said it's the best decision I've ever made for him. We also met with the hospice social worker. We filled out some paperwork so that it's clear that the intention is he should not go back to the hospital if at all possible. Hospice should be able to provide for comfort care measures there at the nursing home. He's getting hospice aid coming, also music therapists, massage therapists, as well as the hospice RN visiting him regularly. So all those staff members added. And if you don't know, Medicare pays for those costs. So that is no additional cost to them for all those services. Jennifer has continued, and this is a point I really want to make. She has told me many times how grateful she is for those discussions back in 2010, because she knows, after having gone through that discussion, that Douglas expressed his wishes to her clearly at that time. So the decisions she's making today on his behalf, she feels are really truly his wishes. And so just to sum this all up for myself, along with, as Sandy mentioned, as a care guide, I help patients, work through all these questions. But the other thing, I'm certified too in advanced care planning, both basic and disease specific. I do healthcare directives with my patients. We fill out if you know of a pulse. We do all kinds of paperwork to record those wishes. So I'm really grateful in my role that I've had that specialized training and have been able to bring that to my patients and families.
So hopefully you've got a flavor of how we could do this differently. How do we approach serious illness in the last 2 to 3 years of life so that all people are getting more of a human-centered, person-directed, so we're really asking what matters most to you first, including the family, before we actually leap in and support patients and families. So I'm hoping the sample of the questions are something that you might be able to take back for either your own personal use or back to your care setting. And we have time for questions, about 10 minutes. We went a little bit over.
What if family members disagree? And what if the person with memory loss doesn't remember what he or she did and is still able to talk?
Yeah, so the question is, what if families disagree? That's always a challenge. And so it's recognizing that where everybody's disagreeing and how you want to move forward. And so it's not always something that we can answer, but we also want to make sure that we're actually having proactive conversations. So the care guide really helps to make sure that they're getting people together upstream rather than the surprise at the end or at a time of crisis, because the daughter from California is always the culprit to come in and swoop in and say, you need to do everything for mom or dad. And so part of that is that we're doing these proactive conversations using these basic questions so that the family is part of the conversation from the start. We're not going to avoid conflict, but they aren't going to be, the care guides are not the mediators. They're really to try to help get people connected. They aren't trained as a social worker or as a psychotherapist. So, good question.
I think there's an option. I don't know.
Where are you?
I don't know if you've. I'm right here.
Okay.
I don't know if you've brought this up, but the one option is not to do specific healthcare directives. I want this, this, and this, and I don't want this, this, and this. Doing a durable power of attorney and having discussed that with your agent, that the person who has power of attorney is a way to do it, and you can let your family and friends know that this is what you've done and that you expect that person to act in your stead if you're not able to.
Sure. So that there are legal things that we want to make sure and have conversations about. And we didn't share the financial legal questions that we have, but we do pursue that. The challenge is just having a legal paper does not eliminate the need to have a conversation. And so the challenge is all that legal stuff we want to make sure people do, but are you actually having a conversation about values, goals, beliefs, how your culture comes into it, and what matters most to that person? What do you think quality of life is for the loved one you're advocating for? So thank you for that, sharing for that.
Great, thank you so much. Thank you for your time. Thank you for everything you shared with us. I'm over here.
There you go, okay.
I wanted to know about the care guide. At what point would a care guide come into someone's life? Would it be in the nursing home? Do they have to be connected to your program before things happen? At what time can you get a care guide to?
Sure. So the question, how do we get connected? And we're really trying to focus on, we're not trying to be a replacement for all the other great care people can receive. And we really want to be more to help sustain people with a long-term relationship. So we're trying to target people that are sick enough to need support, that they would be in the last few years of their life. So we're targeting that through our medical record, and then consultation with the physician or the care team about getting connected to the patient and family. For the research, we actually reached out to families and said, do you want to be part of this research? As we go towards system integration, physicians and care teams will have the care guide as a resource, and as they target people that are nearing more towards the end of life, they will get patients and families engaged with that. The challenge is that not enough people sign up for hospice, and those that sign up typically in the last 2 weeks of life. And so if we focus on prognosis and how long I have left to live to be kind of the trigger, no one's going to sign up because no one wants to think they're going to die. And so we're really looking for what are the things that really are critical from a whole person perspective that people start needing support for as their illness advances.
Yeah, I really like how she was the bridge to bring in the hospice team, and so I was really thinking that would be a good way to get people more introduced to hospice as well.
I'm going to speak on behalf of Judy. Judy's just excellent, and it's really the being with, respecting, listening, guiding when need to, and that long-term relationship that actually provides a level of trust where patients and families share things that they don't often do in a clinic visit because they're wanting to put their best behavior on when they go into the clinic setting. So they might not always share. And then they're the eyes and the ears for the care team out in the community. Thank you.
It sounds like you do a great service, but I want to mention that my husband is signed up with the hospice already.
Great.
I was the same way. Oh, what that means it's close or something, but I was assured no. And it's amazing what they provide, just what you suggested or mentioned. Music therapist, massage therapist, he's loving all of it. He doesn't really know where he is or anything, but all these things are really comforting and caring. And thus, I feel better about, day-to-day operations there because he's getting these extra tidbits of loving care. So you know,
Kind
in
of relieving
addition
a little
to-
bit of the stress for you.
Right.
Yeah,
It's really
that's
helping.
very nice.
And I have a quick question about DNR. I have, for myself, I have it, and now I have it in place for him, as well as the medical directives plus DNR. And then when we just moved here in the fall from New Hampshire, and I did not know what a POLST was. Can you just explain that? I had to. You have to have both, right?
We weren't going to include that detail
Oh,
because
I'm
we thought it
sorry.
would get too
Well,
deep.
is
But
it too
since you
much?
asked, no.
Only if you have time.
So
Thank
about
you.
4 or 5 years ago, the state of Minnesota and the Minnesota Medical Association agreed on a standard form for patients and families to fill out to actually lift up specific preferences that can be put into a medical order. And so a healthcare directive typically is fairly vague, and it talks about broad wishes and general scenarios that typically are about when I'm dying, here's what I want. And so that leaves the great divide of, as you're trying to treat your illness and you have complications, how do you want the care team to treat you? And so the POLST, Provider Order for Life-Sustaining Treatment, helps to articulate what your code status might be, your goals of care of how far do you want to go. Do you want to go in the hospital for treatments? Do you want to go in the hospital but only treat a few things? Or do you want more comfort care? And then do you have specific wishes around treatments such as tube feedings, treating infections, antibiotics, dialysis? So your physician should know about that, and your care team should know about it. So it's pretty broad use, and most nursing homes are starting to adopt them. Great question.
Yeah, I have one. I'm getting the impression that it's really important to put a person with dementia through a lot of testing to find out exactly a diagnosis, and I'm wondering why that is, if different dementia diagnoses have different life and life scenarios, if that's why, or what's the point of putting them through all that testing and going to a neurologist?
So the question is the timing of the testing.
Is it even necessary? We have dementia. Do we have to call it Alzheimer's?
Sure.
What is the value of those specific diagnoses?
So the challenge for testing is that it actually starts the ball rolling on resources, and the way things are documented, it actually opens up access to resources. So that's why screening and identifying is important. I would say that when people get closer to the end of life, what's that?
It's all the same.
It's all the same. It doesn't matter what kind of dementia diagnosis you have it. And the typical trajectory is that little meandering trajectory, and we know typically with people with having dementia type things, they are not going to die from dementia. They die from a complication that they experience that they never recover from. And so the toughest part for families is deciding when you're going to treat that next complication, when you're not going to send them back to the hospital, when you're just going to approach the next ammonia to keep them comfortable, or, if they aren't able to eat or drink on their own, are you going to make sure that they're hand-fed? Or are you just going to let them eat and drink if they actually want to? It's all those, as Judy said, almost daily decisions that caregivers end up having to face. And it's tough. It's really hard. It's really hard. So I should give Judy an opportunity to answer too. Other questions?
Okay, over here.
Yeah.
I have two questions. One is, who pays for the service of having a care guide? Is it something that's covered by insurance? And the second is, I love the component of involving the families. But have you ever worked with individuals who really don't have any support whatsoever, and how does that change your role with them?
So I'll talk about the payment, and then you can talk about. So the last 4 years have been about research. So we've been privately funded, and so we know that we're not going to get private funding to do this forever. So it's the right thing to do, and it's really the way to take care of a population of people at the end of life in a holistic manner. And so with going towards more of a value-based payment, we've been working with our leadership to say we have to figure out how to do this and how to support people on a continuum versus an episode of care. Because the way things are paid for today right now is if you get a test, the system gets paid for it, which really perpetuates doing more and more and more, and that's not what you need at this time. And so we're in the process of working with payers to help develop a benefit so that it will be more of a long-term reimbursement. As a health system, our CEO is committed to integrating this into the health system and having it be part of normal care. The idea would be that long-term, it's part of Medicare as an advanced illness payment model. And we're partnering with people in Washington. There's lots of details of what we're doing around that. So, yeah.
I have.
So you asked about support. So I do work with patients that have virtually no support as far as what we would see in terms of family support. And, you know, as a care guide, since I'm in a long-term relationship with many of these patients, we explore those over time, help them to find community resources. You know, just look at, as Sandy said, we're really looking at what are their strengths, because I think sometimes they look at, well, what am I going to do? So, but I think too, for anyone who I know has their support system is, you know, less substantial than some of my other patients, that's where anticipating needs comes in for me. Let's think ahead, and what if this happens, and then what are you going to do? Who could you turn to if you need a ride, or, you know, things like Metro Mobility, for example, for someone who can't get transportation any other way, works very well for many of my patients. So that's really what we do.
The care guide has been referenced as a really smart family member. That's one of the doctors said, oh, you're just like a really smart family member. So
Thank you for this discussion. Would you just comment in general about red flags for beginning hospice the final 6 months? In a demented patient who is non-communicative, what would be some really broad things for us to be aware of or think about?
as someone is advancing in the dementia realm, they're eligible for hospice if they've really looked like they're not interacting much, so they don't speak. Maybe they have few words that they speak. They are only up for a few hours out of the day. And what I mean about being up is that they're actually able to get up and participate. It's not about getting the Hoyer lift and putting them into the Jerry chair that totally supports their head and wheel them out to the day center. So that's someone who's very hospice appropriate. It's someone who is probably not eating much, so they're losing weight, and they're having complications as a result of the dementia. So they're not able to swallow, so they might have recurrent pneumonia. They might, because they're more immobile, having wounds that have infections or repeated urinary tract infections. So when there's signs of those things, they're eligible for hospice. Does that help? Okay, thank you very much. We'll stay if you've got questions.
Thanks so much, Sandra. That was great.
Yeah.
Wonderful, wonderful talk.
Okay.
Well, thank everybody here. I want to thank all the presenters. Thank all the volunteers today, Veronica and Emily, who have been floating with the mics all day. Everybody at the front desk, Helen, Barb, my colleagues from the School of Nursing. So a couple of final points. If you could, please make sure to fill out your evaluations, registry forms if you're interested, and those yellow forms if you're interested in the remote health monitoring study. Just put them at the big box at the end of the registration table. Just drop them off there, and thank you so much. I have free folders of materials still left over, including some DVDs, again, on the registration table. Grab as many as you want, otherwise I'm recycling them. For those of you wanting CEUs, we're all set up at the registration desk for you, so head on over and we'll get you taken care of. And remember, I'll see you next year, Saturday after Memorial Day. Appreciate it, everybody. Thank you.